Just to introduce the Chief Instructor, Dr. Vanashree Nair. She's a prolific left-handed cataract surgeon who believes in innovations and has picked up into the big league very fast. So over to you, Vanashree.
Thank you for the kind words, sir. So I'll begin with my presentation. I'm talking about floppy iris and the small pupil and how you can safely manage these cases. So let's begin. So as we all know, it is a triad called IFIS, where what happens is there's an intraoperative billowing of the iris, there is progressive meiosis, and prolapse of the iris tissue through the clear corneal wound. So there are 3 grades of IFIS, mild, moderate, severe, and as you can see in this order, if you have all 3, then definitely it's grade 3. It's more common in males, we know that all, but you should always remember that there are females who can also be affected by IFIS. So history of hypertension, diabetes, hypothyroidism, they are on multiple drugs, and these drugs can also cause IFIS. So this is an exhaustive list of drugs which can cause IFIS. We all know tamsulosin is implicated, but also we should keep in mind these other drugs. And if the patient is, bronchial asthma patient using inhalers, schizophrenia, antipsychotics, antiplatelets, all these are also implicated. So first it was described by Chang and Campbell in 2005, and it is the blockage of the alpha-1 adrenergic receptors, and that affects the dilator muscles of the pupil, that is the iris, and that's what happens. So clinically what we should look out for is sometimes what you'll have is a smooth, featureless iris. If you look at that and if the pupil is not well dilating, then you should keep IFIS in mind. And if the other eye has been operated before, then look out for iris atrophy and all these features which will give a clue that the surgery went difficult at that time. So how do we manage IFIS? So first, as I said, be vigilant about it. Look out for subtle signs of IFIS, a moderate dilating pupil, fluttering of the pupil margin when you go in, and so on and so forth. So let's look at the first case. So this was a case which was moderately dense nuclear sclerosis, planned for a toric IOL, and a moderately dilating pupil. So I thought that it's okay, I can proceed ahead. I do my incisions, I do the hydrodissection, and this is where actually the things begin, that the pupil started coming down. And so now I know that this is somewhat kind of a mild to moderate IFIS, but I decide to manage without a pupillary dilating device. I proceed ahead. I am going ahead with my trench, dividing the nucleus, and as you can see that the pupil keeps coming down in between when the chamber is not completely stable. So here when I come out, you can see that the pupil has come down. I wanted to put more viscoelastic, heavy dispersive viscoelastic, so that the iris remains down and doesn't come out of the wounds. So I go in again, I do the subchops, and I'll speed up a little because I want, here you can see that the iris has started coming to the side port. A little bit of iris is coming and trying to plug the side port, but I continue. It is not a very leaky wound, so I know that it is going to be okay. As I proceed ahead, I thought of hydrating the side port. This is another trick that you can use if your iris is popping out. So what this does is it seals the wound a little bit and makes life a little more comfortable. But as I'm proceeding ahead, the iris decides, no, I'm going to be a little more mischievous. And it starts slightly popping up, but I'm much more comfortable here and can proceed safely. So when you're doing irrigation aspiration, when you go in, ensure that your irrigation is off when you go in, otherwise the iris can pop out. And also the bottle height should be a little low, so that bottle height or the IOP, so that the chamber is not too tight and gives a reason for the iris to pop out. So here you can see that the pupil has come down, but it is okay. I can still comfortably go and implant the IOL, check the toric marking alignment, and that's done. Coming to the next case, here what happened is, again, a moderately dilating pupil, but this patient had, the other eye also had IFIS, so I knew that this can trouble me. You can see the little fluttering, not much, but the pupil is not dilating with the adrenergic agents. So here I decided to use a pupil dilating device, that is a Malgin ring, so that my life is much more comfortable when I'm going and doing the phacoemulsification. So I've just demonstrated here how you can use the Mulligan ring to keep the pupil well dilated. So you engage all the scrolls into the pupillary margin using the Kruglin's hook. And there you have a well-centered opening. We can very comfortably do the rexis. That's the end of the rexis. And as you do hydro here, you'll see that the iris is, trying to come out at the main wound. There the irises come out. So here, actually, I should have just moved the Mulligan ring a little away, and it would have taken things in this thing, but I had to take the iris in first. Go in with your phaco probe, and I'll just go a little ahead because this is a normal nucleus management of the case, which is much more comfortable again because the pupil is well behaved and the iris is not popping out. So here, as I end the phacoemulsification, you can see that the iris is tending to be out from the main wound. So imagine if the Mulligan ring was not in place, it would have been quite a troublesome thing to deal with. But here it is okay. I put a dispersive viscoelastic to again, nudge it in. It's again tending to go out, so I'm tempted to use the iris repository through the same wound, but ideally it should not be done. You put a dispersive viscoelastic there and the iris stays back because you need to implant the IOL, which will be easier if the iris is not popping out over there. So there goes in the lens, and you take the Mulligan ring out, and there comfortably your surgery is over. So take home points are that you need to be vigilant that IFIS can present anytime. Use lower IOP, smaller wounds, use the dispersive viscoelastic to control the movements of the iris. And if you're suspecting a severe IFIS, please use a pupil dilating device. You could use either of the rings or even the hooks do very well. And